Taking blessings of Lord Ganesha, Vakratunda Mahakaya, Surya Koti Samaprabha, Nirvignam Kurume Deva, Sarva Karyeshu Sarvada. We'll be starting our first session, Samvad, in association with ISPAT, FOGSI and Solapur OBGY Society. To start with panel discussion on NIPT, I would like to invite moderators Dr. Ajit Patil sir and Dr. Sharad Gogte sir. Dr. Ajit Patil sir is Chief Consultant and Director at Pristine Fetal Medicine Unit, Kolhapur. He is ex-professor and HOD, Department of OBGY, D.Y. Patil Medical College, Kolhapur. He is trained in obstetric ultrasound at Mediscan, Chennai. He has been conferred FICMU by College of Medical Ultrasound. He has FMF certification in 2007. He has started fetal medicine services in Kolhapur since 2005 and first fetal medicine unit of Western Maharashtra. He has performed over 17,000 diagnostic and therapeutic procedures so far. He has trained PG students for MS, more than 75 research papers and presentations, delivered about 400 lectures at various conferences. He has contributions to various textbooks. He holds a Limca Book of Records in 2008. His hobbies are long drives, rally driving, natural treks, and jungle safaris. He conducts training programs in basic OBG ultrasound, and he has trained more than 100 doctors so far. He has started the Down Syndrome Support Group in association with Down Syndrome Federation, India. We welcome you, sir. Dr. Sharad Gogte is currently fetal medicine consultancy services since 2005 till today. His academic achievements are gold medalist in MD, FCPS and DGO examination. He has been invited on the International Board of Advisors of American Journal of OBGY for a period of 2 years in 2007. He has been invited on the Board of Editors of Prenatal Diagnosis International Journal for years 2011 till date. He is peer reviewer for Obstetric and Gynecology International Journal. He is editorial advisory board member of MD Current India. He is his own board of reviewers of Indian Journal of Fetal Medicine. He has won many awards like Mother Teresa Excellence Award for outstanding achievement in the field of obstetric and gynecology. Welcome, sir. I would also like to invite panelists for today's session, Dr. Keval Patil. Dr. Keval Patil is fetal medicine consultant, consulting obstetrician and gynecologist, Matruseva Super Speciality Center, Meerut, and Matruseva Hospital, Shedbal. He is successfully performing fetal interventional procedures over a period of 5 years, including intrauterine blood transfusion, fetal reductions, chordocentesis, amniocentesis, chorion villus sampling. His areas of interest are management of cases of recurrent pregnancy loss, first trimester scan and screening, and management of cases of IUGR. I would like to also invite Dr. Saket Thakar, his MD in radio diagnosis, his fetal medicine and intervention at Vatsalya Fetal Medicine Care, Pune. Dr. Saket Thakar is a fetal medicine and intervention specialist practicing. Not here, okay. I would like to invite Dr. Raviraj Gondkar, his consultant fetal medicine, Vasuraksha Fetal Medicine Center, Kolhapur. He's member of Fetal Medicine Foundation UK, member of International Society of Ultrasound in Obstetric and Gynecology, member of Kolhapur Medical Association and Kolhapur Obstetrics and Gynecology Society and FOGSI. He's former associate professor, Department of OBGY, RCSM, Government Medical College and CPR Hospital, Kolhapur. He has presented many papers and written original articles in international journals. I would also like to call Dr. Ankur Shah. He is MBBS, DGO, FCPS, OBGY. He's done fellowship in Advanced Obstetric and Gynecological Ultrasound from Mediscan, Chennai. He's member of Fetal Medicine Foundation, UK, member of Society of Fetal Medicine, India, member of the Association of Fetal Medicine Consultants, Maharashtra, member of the Malegaon OBGY Society and FOGSI, and member of IMA Malegaon. His areas of interest are first trimester NT-scan, TIFA scan, fetal echocardiography, fetal Doppler study, and fetal interventional procedures such as amniocentesis, CVS, and fetal reduction. He's presented paper on FIFA syndrome in MOGS conference Shirdi in 2016. I would also like to invite Dr. Ankita Deshmukh. She's consultant obstetrician and gynecologist with subspecialty training in maternal fetal medicine and gynecological ultrasound. She's done fellowship in advanced obstetric and gynecological ultrasound from Mediscan Chennai. She specialized ultrasound training in endometriosis mapping from US, from Brazil. She's done fellowship in gynecological endoscopy also. She's MS Obstetric and Gynecology from Sir JJ Group of Hospitals, Mumbai, and she's founder member of Fetal Brain Society. So I would like to request moderators to start with the panel discussion.
Friends, good afternoon and welcome you all. I'm Dr. Milind Shah. Friends, probably you may finding a little less crowd here, but you know there are 114 people who are logged in, 144 people who are watching you. They are watching you as well, your answers and the questions. So it will be wonderful interactions. My request to all those people who are logged in, they can also put their questions in the chat box, and there will be one person who will be assigned to see your questions, and we'll try to definitely answer those questions as well at the end of the sessions, at the end of every session rather I would say. So friends, let us start with this wonderful session. Very good start by very good stalwarts in the field of fetal medicine, by a wonderful discussion on one of the very good non-invasive method NIPT in the field of fetal medicine. So please start your panel. Thank you very much.
A very good afternoon to you all. Before we begin, let me thank the Solapur OBGYN Society, the office bearers of Solapur OBGYN Society for inviting us to Solapur. Solapur has always been my second hometown. I had my MBBS, MS and some part of my lecturers post at Dr. BMMC with my teacher Dr. Dabde, and soon I'll be meeting Dr. Sardesai also. So Solapur हे माझं तसं दुसरं गाव आहे. सगळ्या गळल्या, सगळे दुकानं आणि सगळे ठेले माहिती असलेलं गाव आहे माझं. So इथे यायला केव्हाही आनंद असतो. Today I am very and again it's a pleasure to share this dais with Dr. Gokte, a very senior person from Mumbai, and we'll be taking you across some of the difficult issues in NIPS, the non-invasive prenatal screening. The overall structure will be that Dr. Sharad sir will take you across the technicalities and some of the issues of NIPS, and then we'll go on to some cases. The cases are actually real life scenarios, the ones that we have faced in clinical practice where decision making was really tough. And we have a learned young faculty here, the panelists, and they will be taking the exam, I suppose. So Sharad sir, please.
Good afternoon. I am Dr. Sharad Gokte, and I am very happy to see 5 consultants in fetal medicine at one go. I remember when we started our initial work, people said, why are wasting time? We are doing more than enough for the mother, and from there baby is going to taken care of as such. From that, people taking interest and choosing this field of fetal medicine is a very heartening feeling to me. Today our topic is NIPS. Initially it used to be called NIPT, and we used to call, but it is not diagnostic test, it is a screening test. NIPS is a very accurate, most accurate screening test for not only aneuploidy but other chromosomal, structural, as well as microduplication, microdeletion type of abnormality. So it is not just trisomy screening. But let me tell you that all of us are getting so much carried away with aneuploidy screening that we tend to forget that there are more important entities where screening is possible. like hemoglobinopathy, metabolic errors, this muscular dystrophy, so all of them require screening and they have much more severity, but we tend to forget about it. I know gynecology, I have done NT scan, I have done double marker, so genetic workup is over. That is not the case. We have to see that we do justice to everything. Now, this test, as I said, initially the first time 1997 cell-free fetal DNA was identified. But even before that, in 1992, the first time fetal cells were intact fetal cells were isolated from maternal blood. And they tried to do, but the number of cells were so few that test did not catch up. And in the meanwhile, this cell-free DNA test advanced, and today it has become a very highly advanced test. But we must remember that however accurate the test it is, its effect and its value will be if it is understood first by the clinician, patient, counselor, laboratory people, fetal medicine people, and then only it will have its best value. If otherwise clinician like sending CBCS, or if we send sample for NIPS, it is not going to work. It will create more problems because they will not. So most important thing in my opinion is pre-test and post-test counseling, which has to be on a standard pattern. So there should not be any difference, so the patient gets information from everybody, same information gets. Secondly, we have to understand its limitations, that it is a highly advanced but screening test, it is not a diagnostic test, and it has to be emphasized to the patient that whatever the result comes, in case confirmation is required, invasive test is a must. Secondly, there are certain conditions where it may not yield proper results. I'll just go to that slide. This is most important slide, you must understand. In the maternal blood, if the fetal fraction is less than 4%, then it becomes no call test. That means we cannot give you a result. In presence of active or concealed bleeding, it is going to be vitiated because placental separation has happened, so more fetal DNA is going to go into circulation. So if patient gives history of bleeding recently or a subchorionic hematoma, you will not do NIPS, or you will not do even double marker, because that is going to be affected by this event. Thirdly, in case of vanishing twins, again you should not be doing NIPS, because the vanishing twins fetal DNA is going to be mixed in the blood with the viable fetus. Multi-fetal pregnancies, more than twins, NIPS has no value. In case of twins also, the sensitivity is not as good as in singleton pregnancies. So these limitations must be understood by everybody, and once this is understood, then it will be easier for you to give best possible result and benefit to the patient. Another important point is when you do NIPS, it is mandatory that a viability scan has to be done in first trimester. That will tell you exact period of gestation. That will tell you whether it is a multiple pregnancy or single pregnancy. That will tell you whether there is a presence of a subchorionic bleed. And all these things are very much important. Then if NIPS test is normal, and still NT scan is must. Because NT scan has a value of its own. It is considered as the first anomaly scan, first fetal maturity scan, first genetic marker scan. So it has to be done, whatever happens, the result of the NIPS. So these are some of the points which I want to emphasize on. And another important thing is we are missing one big opportunity by not getting RH typing from NIPS. In RH isoimmunization management, if you can know the fetal group, it makes the management so much logical, easy, and saves a lot of hardship and expenditure. Unfortunately, in India, so far there was no lab available doing this test, but now MedGenome has come forward with RH typing from maternal cell-free DNA, fetal DNA, and which is almost 97, 98, 99% reliable. So this is something which you must keep in mind, and unless we have a demand, the test is not going to be made that much easily available. So these are some of the points which I thought I should share with you. And the guidelines, as in India, we have a peculiar problem. We have got excellent facilities in metropolitan cities. But the moment you go 50 kilometers away from any major city, no facilities are available. So you cannot use NIPS as a universal screening first step, because which is tempting. Why do double marker? Why do anti-scan? Why don't we do directly NIPS? But that is not the case. NIPS is going to be possible if first of all it is available across the entire population. Secondly, its cost is manageable. Thirdly, people understand what is to be done with that test. And all these things, and further pre and post test management also has to be in place. Either you do NIPS, but then who is going to guide the patient if the test comes positive? And if the test shows high risk, then interventional procedure for confirmation of diagnosis is a must. And that is something which has to be emphasized. I think I'll stop over here because there will be more time for discussion. In case you feel there's any other point I would like to cover, please let me know.
हे चालू आहे हा चालू आहे तो त्यांना दिला with this very nice brief on NIPS by Dr. Sharad Gokte, I think we'll just move on to clinical scenarios. As sir has pointed out, we all know how NIPS is done. So a mother will walk in the clinic, a sample will be withdrawn, the sample goes for testing, and the laboratory will have various different ways of testing for NIPS. And the machine is like, the laboratory report is like a pack of cards, and those of you who play with cards, you will understand what hands you will get is always a confusion. So that's where the confusion begins, and once the moment you get a report, I think our headaches begin. And so the fetal medicine consultants are here. They work like your paracetamols or aspirins to take away that headache of interpreting the reports. So I think with this brief understanding, we'll go to cases. And these days you will be getting these type of patients actually. And meet Mrs. Anita. She is 34 years, a vice president in marketing, ABC Capital Ventures. And ABC Capital Ventures, you understand, comes with a lot of money. So being empowered with knowledge and money, she decides to go for a NIPT on her own. She walks to a lab, tells them that she needs an NIPT test to be done. The lab is very happy to receive a client who is ready to pay 15,000-16,000 rupees. So without consulting a doctor, she has gone, given a sample, and she comes back with a report. And the report is positive. Now with this report, and because she has read the report and the lab has put a red dot there, she comes to you for an MTP. She says, "Ki doctor, this pregnancy is affected by Down syndrome, so I am considering termination of pregnancy." So I think Dr. Keval will start this discussion nicely. How will you proceed this case now? She has done an NIPT on her own at around 10th week with a positive report of trisomy 21. She has come for you to saying she wants an MTP because this fetus is already been tested positive for trisomy 21. And she reads in between the lines. Remember, she's empowered. She reads in between the lines with a sensitivity of 99.9% for trisomy 21. She thinks this is almost a diagnostic test and this fetus is already affected.
Yeah, good afternoon everyone. As you know, she has done a screening NIPS at 10 weeks of gestation. Ideally, the scenario should be, there should be a pre-test counseling and then the post-test counseling after the report comes. But here, as she has gone walk into the lab and she has done NIPS, she has directly come with a post-test counseling. Now, when we come across the report, we look for the fetal fraction of the NIPS report. So, I would like to know what is the fetal fraction for this?
I guess the fetal fraction was 2.78.
Yes, sir. So, at 10 weeks, the fetal fraction, as you know, we should get a fetal fraction which should be more than 4%. Now, you can know, you see here it is a 2.78%. So, ideally at 10 weeks, there is high chance of false positivity for NIPS. So, this should not be performed at early gestation. Ideally, it should be performed at around NT scan or maybe after that. So, considering the fetal fraction, the test has come out to be, could be false positive. Still, we have to put up a point to the couple saying that this could be false positive, but we'll go ahead with a thorough NT scan and then we'll comment on what we can do further for whether to go for a diagnostic testing or what are the options available.
First of all, if it is 2.78, I will call it no call test. We cannot take the opinion on this test seriously because basic criteria of fetal fraction is not met. Secondly, the test, as one point I forgot to mention, that we must remember that in NIPS, what we are testing as fetal cell-free DNA is not actually fetal body cells. It is from chorionic villa cytotrophoblast. And you know that there is placental confined mosaicism or abnormal reports which are seen in fetus, which are not seen in the placental sample but not seen in fetus. Because placenta is a short life disposable organ, while fetus is going to have a long lifespan. So genetic integrity which is maintained in the fetal DNA is not maintained that rigorously in placental DNA. As a result of that, you get false positive tests after NIPS or after chorion villus sampling. If you get an abnormal report in chorion villus sampling, we tell the patient confirm it by amniocentesis. Because amniotic fluid cells are more really containing fetal origin cells from fetal skin secretion. So it is really true fetal fraction. This is not a true fetal fraction.
So I think Dr. Keval has brought out two, three important points. Number one is we should read the report in detail. It's not just concentrating on those red dots or green dots and come to a conclusion of whether the test is screen positive or the fetus is screen negative. So there is something in between or fine reading, what is the Z-scores, what are the fetal fractions that the laboratory has reported. And that brings up a very interesting point of pre-test counseling before the patient goes for an fetus goes for a NIPS test before, the pregnancy goes for a NIPS test before. That's the pre-test counseling is very important. The patients, I think it's like HIV testing. We need to counsel the patient as to why she is needing a test and how the test will be done. So that mechanism or that way of taking the test should be done. And of course, because she had given a sample to a lab without consulting a doctor, and the lab had also not bothered to report about the fetal fractions here. And you can see the fetal fraction was 2.78. So the very reliability of the question will be a big question mark on this NIPT report. So as he rightly said, I think this patient underwent an NT scan, so he could convince the patient ki wait, don't take such a hurried call, let me do a scan before you take any decisions. And he has done a scan, and you can see the scan report shows the, depending upon the ultrasound markers, the adjusted risk is very low, almost 1 in 6,341. So her age risk was 1 in 317, and after the scan it has become 1.6. Very rightly he suggested a repeat test, and this is the repeat test. So yes, so what was the wrong here in this testing? So he has again rightly addressed it was the issue related to a low fetal fraction, and that brings up a very interesting point in our discussion as to what should be the optimal gestational age for doing the test. Should the ultrasound be done first before doing the test, or should the ultrasound be done later? And what mechanism should the not labs, what mechanism ideally the lab as well as the center should have to address the screen positives? Keval, what are your views? I think that the rest of the panel can also contribute. It's not only restricted to Keval. So Ravi and Ankur and Ankita, please come out with your opinions on. So we are now have 3 questions here to address. What should be the optimal gestational age for doing a test? Though we know the NIPT can be done, NIPS can be done anytime after 7 to 8 weeks of pregnancy. Is it a right step to do NIPS at 10th week? That's number 1. Number two is, should we do an ultrasound before? Ultrasound, I mean not the viability scan, but the NT scan. So should we be doing an NT scan before or after the test, and what mechanisms we should have in place to address the skin positives? Keval, please.
Ideally we do a proper NT scan at around 11 to 13 weeks, 6 days, and depending upon the soft markers or any findings during an ultrasound, then we go ahead with NIPS along with the NT scan. So this should be the protocol ideally which should be followed, because early NIPS will lead to false positive results, and unnecessary panic situation does appear at that time. So doing a NT scan and then followed by NIPS is the ideal scenario in any of the cases.
Should we do ultrasound first, or that you have addressed it? Yes. But by doing ultrasound first, by doing the test first before doing the ultrasound, so we do an NIPS, say for example at 11 to 12 week, and then the patient comes for aneuploidy screening, is it not relieving the pressure on you that the patient is screen negative? So probably I may not spend that much time in looking at DR, say for example ductus reversal, tricuspid regurgitation, which are very difficult points sometimes. So probably if I have an IPS report which is negative, screen negative, does it not relieve my pressure of looking at the scan from aneuploidy point of view and concentrate more on the structural anomaly scan? If we have an aneuploidy, and if you have an NIPS report in hand?
Sir, if we have multiple markers during our NT scan, then it does change our modality of testing. So if suppose we find an increased NT or a couple of isolated markers which are there during NT scan, then we directly go ahead with the diagnostic testing like chorionic villus sampling or amniocentesis. So it does, the testing varies depending upon the scan findings. So we ideal scenario would be doing a NT scan and then going ahead with NIPS, or whether we have to go ahead with diagnostic testing.
The rest of the panel, you have any different opinion on that?
Yes, sir. I totally agree with Dr. Keval, sir. The purpose of doing NT scan is many things. First, to confirm whether it's a singleton or no. Because NIPT is a being screening test, so far we are giving more importance in a singleton and to some extent in a twins. So not only just it's a number of fetuses, then the structural normalcy of the fetuses. So in that case, we are going for all the markers, be it a NT, be it a nasal bone, ductus, tricuspid regurgitation. Because NIPS being a screening test, we are going to advise only if fetus is structurally normal. So first we have to confirm whether it's a single and it's a structurally normal. Then it becomes an indication. So it stands, or there is the importance of ultrasound done first, and then SOS we can advise NIPT. And at the same setting we can take history also. Because if history of previous baby with Down syndrome, the type of Down syndrome, whether it was just a pure trisomy 21 or it's a translocation type of Down syndrome, again scenario changes completely. We are not going to advise NIPS in a case of translocation type of Down syndrome, and in that case invasive testing will be mandatory. So ultrasound will give chance of taking history also, and at the same time we will have some important inputs, so we can safely go ahead with the NIPS.
Ankur?
Actually, sir, if we come across any structural abnormalities in the fetus during the scan which are pointing towards some specific genetic syndrome, or if the patient has a history of prior baby suffering from any genetic syndrome, then we can directly counsel the couple rather than going for NIPS to directly go for invasive testing, where we can also proceed with the chromosomal or karyotyping with the exome sequencing to rule out the findings which are supportive for the genetic syndrome which we are thinking of, or if with the findings which we are seen in the first baby. So this will make our diagnosis more accurate.
So in a sense, you would like what you are saying is that NIPS, though comes patient, say suppose the NIPS report is screen negative for Down syndrome, but the patient has got an NT of say 3.3, or the ductus shows a reversal, or if there is a tricuspid regurg, you would still go ahead with an invasive test.
Yes, sir, that would be a more prominent thing, because it would give us a diagnostic test, because at the end NIPS is a screening test only, and we are getting positive markers in the ultrasound which is conflicting with the NIPS report. That's why.
So yes, I think important points that have come out of this discussion is that a scan is must before patient goes for an NIPT, NIPS. Sorry, I am confusing between NIPT and NIPS all the time. So a scan is must before the patient goes for an NIPS, and the scan markers are important. So the markers of aneuploidy on the ultrasound, that is the nuchal, the DV, the nasal bone, and the tricuspid ligament, the four important markers are not only for aneuploidy, but they are also important for rest of other things. And we also keep in mind that these markers could be also a pointers towards an evolving late fetal anomaly. So the 16th weeker scan is again important, and maybe it should be followed up with an invasive test. So I think Dr. Sharad sir has already addressed this, the discrepant NIPS and the biological factors, that is the placental mosaicism. And he has very rightly said, these are, though we call it as cell-free fetal DNA, these are not fetal in origin, but these are placental DNA. So there could be sometimes a discrepancy in interpretation of placental DNA and fetal DNA, what we call it as placental mosaicism, and that could be one of the important findings of confusion between trisomies. And of course, vanishing twin syndrome, this Mrs. Anita, she went for a scan, she went for an NIPT before doing a scan. So we really do not know whether she had a vanishing twin or not. So there will be some situations where the NIPT test could be confusing. We move on to a second scenario, and she is a very faithful lady. Again, this is a real life scenario. A 28-year-old low risk primary gravida underwent an NIPS, and this NIPS was low risk, and she ultimately delivered a baby with Turner syndrome. Now, since she had already gone in NIPS and she is up in arms, the relatives are up in arms, and they have come to your clinic saying, "Ki, doctor, we had done everything what you had suggested for us, and how come this we have delivered a baby of Turner's?" So, Ravi?
In this scenario also, it emphasizes or importance of 2 points. One is doing ultrasound first, because in case of Turner or something, we may get something in ultrasound like increased NT, cystic hygroma, or bilateral lymph cyst or something. And again, the second important point is pre-test and post-test counseling. We need to discuss the limitations. We need to discuss what are we expecting from NIPT. So far, NIPT is validated mainly for common aneuploidies. And these kind of sex chromosome issues, as we can see, the sensitivity is less as compared to that of common aneuploidies. So we need to discuss them, the NIPT, after confirming the structural normalcy. It's just a screening test, and that too, it's mainly validated only for the common aneuploidies. So that need to be discussed before going for the test. So in this case also, if we would have discussed the same thing and we would have told her, then it would have been easy for us during post-test counseling that why it came like that.
We have to remember that laboratories, when they are trying to sell their product,
Yes, actually I was
they
going
make
to say.
all sorts of claims. But the bottom line is that all these claims are unjustified. So the patient also reads something on Google. Google Maharaj is always there to help us. And sometimes they may come with preconceived idea, because this is as good as diagnostic test. Why should I undergo amniocentesis? We discussed it already. So we have to be, ethics have to be observed at all levels. Like that lab should not have accepted sample from the patient directly without a referral, as per the PCP/NDT guideline. But when it comes to money, everything goes. So we have to, and secondly, I would make it a habit that whatever pre-test counseling, post-test counseling we do to the patient, it should be put on paper and a copy should be written with us. And one copy, even if it involves little more time for your peace of mind and keeping your pocket heavy, it is better that you maintain some sort of a record, so that tomorrow if she comes again, you can share, you have signed on this is what it was explained.
I think that's very important. If you look at the laboratory sensitivities, as sir has rightly said, everybody will come to your table and start telling them that our lab has got a 99.9% sensitivity, and we are carried away by a fact with a thought that probability is 99.9 stands equal for all chromosomes. So you'll be doing an NIPT, extended NIPT or expanded NIPT. See the numbers here.
One thing, actually trisomy 13 detection rate is around 92 to 95%. It is not 99%. It is only trisomy 21, which is 98 to 99%. So no, nothing is 100%.
So this reference is from where? This 99.9?
These are lab reports. So the sensitivity, today the algorithm is quite well developed, robust for trisomy 21, and then it's followed by 13, 18. The sensitivity for sex, especially for Turners, is quite low. It's just 90%. So not yet validated. So it again brings us a second important point in discussion: the role of ultrasound. As Dr. Ravi has said, we have to concentrate on our ultrasound first, and then let us not rely more on this NIPS, because ultrasound is going to tell you much more information than the laboratory reports. I am an ultrasound fellow actually, so I am slowly, you will understand, I am slowly promoting ultrasound more than yes. Case 3, I think, Ankur. Now she is 35 years old, and I think in metros, women are delaying the age of marriage, and obviously they are resorting to fertility treatments, and she conceives, and she is twins. Now, 12th week, she's come to you again for requesting, doctor, she has read, I have read somewhere that NIPS is good, and now that I am having twins, and this is going to be my only pregnancy, so I want to do whatever best is possible for my pregnancy. I would like to undergo an NIPS test now. She is a twin, established twin gestation, so she has come into anti-scan time, like.
Yeah, that is the main thing which we should know, what is the chorionicity. Because if it's a DCDA twins, the genetic workup of both the fetuses would be different, and in monochorionic it would be the same. So if we do a NIPS in a DCDA situation, and if it turns out to be high risk, we cannot say which fetus is affected and which is not affected. So in that case, at the end we have to go for invasive testing through both the sacs to know about which is the affected fetus, and also do a proper scan of both the fetuses to know if we can see any structural anomalies or any soft markers present.
In short, you will dissuade her from doing NIPS.
Yes, because in twins, and also as she is 35 years old, which is the high risk as such, her age related risk would be higher only. So I would rather suggesting her NIPS, directly suggest to go for an invasive testing only if she wants a confirmatory test, considering her age risk.
Financially matter, you are going to waste money of NIPS, use it for NIPS
Yes.
diagnostic test.
So I think it lot depends upon whether it's a monochorionic pregnancy or a diachronic pregnancy, as very rightly summed it up. If it's a monochorionic pregnancy, I think both the fetuses are contributing the same DNA, so we can interpret. In a DCDA, it becomes very difficult. The problem is again, if suppose in DCDA one fetus is affected, another fetus is normal, the DNA will be diluted by the contribution that is coming from the normal fetus. So if the abnormal fetus is contributing say 50 cells, and this normal fetus is also contributing 50 cells, the concentrations will go down. So it's very difficult to interpret in reports in DCDA twin. And look at the ISPD recommendation now, and it also says that only 3 out of 10 statements recommend self-free DNA screening in twin pregnancy. Others did not address this issue, suggested that data is too sparse or recommended against. So none recommended for or against self-free DNA. Of course, in higher order pregnancies, it's not important. So I think DCDA twins, again, it comes back to our ultrasound and looking at all our ultrasound markers to look for any aneuploidy markers there. And if any of the fetus is having aneuploidy markers, then definitely go ahead with an invasive testing. Suppose one fetus has got an abnormal marker and another fetus is normal. Would you like to test only the normal fetus or the abnormal fetus or both in a DCDA?
I would prefer doing both.
So I would like to add
Yes,
to
please,
it.
please.
If suppose there's a case of monochorionic twins, and on the scan one of the twins has some of the NT is increased and the other twin is normal, would you still go with an IPS or would you go for testing of both the twins, invasive testing?
It depends what are the findings present, like which,
If there is an increased NT only in one of the fetuses, supposing that the DNA of both the fetuses is the same, or the genetic material is the same for both, but on the scan there is a marker for present for one of the twins. So would you be going for invasive testing of both the fetuses, or?
Yeah, because at the end, compared to NIPS, invasive will give you a confirmatory diagnostic finding only. NIPS will not give a 100% diagnosis. So if you are getting a soft marker and it's a monochorionic, if you do only one SAG, it would be a same genetic workup, so both babies' report will be the same only. So invasive would be a better option compared
For
to NIPS.
the one which
No,
has
because
increased
it's a
in.
monochorionic, the report would be indicative for both the babies, as the genetic work would be same for both the twins. That's why.
Again, so in twins, again, I think we come back to the role of ultrasound in monitoring a twin gestation. So ultrasounds are not only important for aneuploidy screening, but they're also important for certain twin-specific issues, and therefore we cannot neglect the role of ultrasound as far as the twin pregnancies are concerned. Of course, confirmatory testing has got a lot of ifs and buts in multiple pregnancy gestations, and monochronic pregnancies and diachronic pregnancies will pose different set of challenges as far as the invasive tests need to be done. And of course, and nevertheless to say the counseling about selective reduction if the patient's reports comes as abnormal.
Again,
And
proper
here is,
counseling is important for
yes,
them.
proper. I think we had taken this case, but just to enumerate another patient, actually she came for a query on NIPS, and luckily I think Ankita did a scan before and she found a fetus which is non-viable. One fetus has got a good anti-markers, you can see the nasal bone and the nuchals, everything. So this fetus is completely normal, DCD twin gestation, and there is another fetus, dead fetus, which is of around 9th week. So there is no history of any procedure done, so this is spontaneous fetal death. And how do we go ahead now? She wants a, or she requests for an NIPT.
I would say if there is a fetal pole present at the time of the scan, I would not go with the NIPS because it will have the DNA of both the fetuses circulating in the maternal blood. So in that case, when such a satisfactory NT scan is done, I can go with an NT-NB risk profile for that patient based on the a priori risk and the NT-NB risk.
But now always there is another sword hanging on our head, and that's dual markers. So what is the role of how the dual markers will differ in vanishing twins?
Again, in this case, there could be increased HCG, increased PAPA because of the second fetal pole that is present at the time of the scan. So again, I have to reassure the patient that structurally and with the markers, this is the risk. But at this moment, we cannot go ahead with any of the screening tests, which will decrease the sensitivity of the test because of the presence of the fetal pole. And then it is their decision, but I wouldn't recommend going ahead with a screening test when structurally and looking at the soft markers, it is a normal scan. And later on, I can ask them to revisit for a scan at an earlier gestation age just to see if any other developing markers or anything is there.
So this is important because today dual markers are done by every lab right from a sample pickup center to some renowned laboratories will be doing a dual marker. They don't have any access or any consultations. It's very important that wherever you are practicing, you have a good tie-up with the fetal medicine fellows who will be able to interpret these reports, because this is the area of confusion. We should not cause no harm to the pregnancy rather than doing any, what you can say, a bad report can cause more harm to the pregnancy. So dual markers will also vary in case of a pregnancy with a vanishing twin, and the beta HCG PAPA levels will also change, and this definitely will have a lot of implications as far as the screening is concerned. Therefore, we need to have a proper consultations on all these patients.
One point I would like to mention, that we must have a dialogue between the clinician, the lab and fetal medicine expert, particularly when the report is showing risk factor. Because the lab also must know the clinical detail, because most of the time sample is not accompanied by all the information. So they go only by the laboratory values, which is an incomplete interpretation as such. So all it takes is pick up your phone and talk to lab, or lab will should talk to you. That much exchange of information will avoid lot of wrong decisions and further complication.
And another patient, you can read the WhatsApp report. Actually, this patient had sent me a WhatsApp on this. She did an NIPT and the patient was reported as screen positive for trisomy 18. high risk case, fetal fraction of 2.78. But this patient was like little curious, ultrasound is normal. So now we have a discrepancy between the NIPS report and the ultrasound, and see this patient, what the patient said. Patient was from a different city, and she got her NIPT done again, and she says, attached to my message a screenshot of my first NIPS result. It was stating that my baby is at high risk of both 18 and 13. I did not stop there and asked my OBGYN if I could get another NIPT done, and to my surprise, this report this time has come back negative even before seeing a genetic consultant. And I just wanted to share my experience with you, and hopefully you will hear the good news very soon. A very talented patient actually.
Understanding patient, I would say. But we must remember that false positivity by NIPS is definitely there. False negativity is that were comparatively very, very uncommon. So if the report is negative, I will believe it. If it is risk is high, I will not. Particularly in 13 and 18, there have to be some structure ultrasound markers in the fetus. If you don't see any, then it goes in favor of a normal report rather than saying that sonography is wrong. So I will take a large pinch of salt, a screen positive report on NIPS.
So overall, probably you are understanding my way of promoting ultrasound more, because we should remember that ultrasound is each other. So prioritizing your ultrasound reports is very important. You need to see the ultrasound reports and then only interpret the test again. We should not neglect the low fetal fraction here, and I think low fetal fraction is also associated with some problems like placental insufficiencies, adverse pregnancy outcomes, some maternal risk factors and maternal factors, and aneuploidy or subtle genetic abnormality. So read the report in detail, look at the Z scores, look at the fetal fractions, and if the fetal fractions are really low but the lab is very good, then we know we should monitor this pregnancy carefully, because this pregnancy is at risk of developing these many disorders if the patient has got a low fetal fraction. So this way this lab failed to report this 2.7, but of course there is much more low fetal fraction. So what we have to keep in mind is all those issues. So yeah, coming back to Keval again, what scenarios you will favor NIPS over amniocentesis then?
Ideally, as per protocol, when the combined first trimester screening comes out to be intermediate risk, we go for NIPS. And any isolated soft markers seen on ultrasound, definitely we have to go for NIPS with due counseling to the patient. And there should not be any additional structural abnormalities, major abnormalities along with the soft markers. If there are any structural abnormalities along with the soft markers, definitely we go for direct definitive diagnostic testing. And to adding to it, increased borderline NT like around 2.5 to 3.5, we definitely would advise NIPS in such cases with no other markers involved during ultrasound. So these are the conditions where we advise NIPS.
So as of today in India, the scenario will be doing a selective NIPS over an universal NIPS. So there will be some cases probably can go for a selective NIPS before doing amniocentesis. But then Ravi, there will be some scenarios where you will be favoring direct amniocentesis.
Yes, sir. First is if patient wants a definitive answer, then it becomes automatically a indication for doing invasive testing. Or doing during ultrasounds, if we find any structural issues, then rather than going for a screening test, it becomes an indication for invasive testing. And also, if previous baby has some genetic issues, or if previous baby has Down syndrome, that too of translocation type of Down syndrome, it is always better to go for direct testing. And also late gestation, or if there is a very limited time for decision making, because NIPS will take anywhere somewhere between 10 to 14 days, means 2 weeks time. Patient has come to us at around 21, 22 weeks. Then going for NIPS, and if at all risk comes out to be high risk, then going for amnio, then it will be time consuming. So it in these scenarios, yeah, we can go for direct testing.
I would like to add, sir, also if in the double marker, if we get a high risk, less than 1:250, then we should, rather than proceeding towards NIPS, directly counsel the patient for invasive testing only.
Ankita, how is the incidence of obesity in Solapur?
Surprisingly, it is okay actually. I have been after Chennai. I think Chennai they had a lot of. Yes, I discussed the same with Sumit sir that I saw a lot of high BMI patients in Chennai, but in Solapur it's better.
Comparatively?
Yes.
Because
So,
obesity is throwing up different set of challenges, I suppose. And are these challenges there for NIPS also?
so definitely because the fetal fraction will change according to the maternal BMI as well. So when there is a high BMI patient, it can affect the fetal fraction, and there's an increased chance of a no-call result in NIPS, which should be discussed with the patient beforehand, before giving the NIPT in that scenario. And
So what alternative strategies for aneuploidy screening then, if your NIPS is not very reliable?
So if there are other high risk factors associated with that pregnancy, such as IVF pregnancy and maternal obesity, then again I would say that there is even more increased chance of having a decreased fetal fraction. So if there is no seeing at the history of the patient, if there are no other factors, we could go ahead with a double marker or a first trimester combined screening, and we can even go for NIPS as per the after counseling the patient about no call results, and if they still want to have a result which is 99.9% accurate for trisomy 21, then we can still go ahead with NIPS, but only after pre-counseling the patient.
Because I guess doing ultrasound in these obese women is also difficult.
Yes.
So maybe probably you'll shift to a transvaginal route than a transabdominal route.
So definitely for NT, whichever route, whichever is the best way of seeing the fetus, both the routes should be gone ahead with.
I
So
would like to make one point about double marker, advanced double marker test. Advanced double marker test where you look not only for aneuploidy but you look for PIH, you look for IUGR, you look for stillbirth. So if you consider all these things, if you are in doubt whether to do NIPS, I would rather go for advanced double marker because I will be covering many more conditions. And secondly, if you pick up risk factor for IUGR at 12 weeks, giving treatment because second phase of invasion starts at 13-14 weeks. So if you do it, then giving treatment at that stage is going to give better result than rather than doing it after anomaly scan, which is at 16-17 weeks. So this is a very fine point which you must understand.
So in that case, one more thing I wanted to ask, if in NT scan, if you discover that the placental mass is low or the area of placentation is low, in that case, would you go ahead with the NIPS with PAPE and PIGF, or just to rule out any chances of preeclampsia individually? Okay.
But if you are thinking that the risk is low, I would rather go for advanced
Just for
double marker.
combined
It
testing.
covers so many other factors.
Right.
So Ankur, now what's your city practice like? You prefer a basic NIPT or an expanded NIPT? Because lab has come to you and tells you, doctor, in same amount of money we can look at all chromosomes. Why look at only 13, 18, 21? We have microdeletions, we have everything. We have so many, all chromosomes we can do a test. Another 1,000 rupees more to the patient.
So actually in my clinical practice had come along one case where I suggested an expanded panel for the patient and the report came out some like minute micro duplication or something which had no clinical significance, though the scan was completely normal, no soft markers, no structural anomaly seen. But with this type of report, it unnecessarily causes a mental hazard to the patient, and then post-test counseling becomes very essential for this time. So it depends upon, first we should do a scan, see what findings we are getting. If we are getting some soft markers which are pointing towards the specific chromosomal anomalies of 21, 13 or 18, so basic panel would be more than sufficient, I prefer.
So, yes, I am just coming to that slide only. So actually, the expanded NIPT though appears very lucrative and attractive today. As of today, the data is not yet validated. So I think we should be still sticking to basic NIPT. And this was the data from the lab, actually one of my labs. And you can look at the rare autosomal trisomies over here, 32. And in our case series also, we did about 450 cases, and there were 2 cases of rat, both came out to be normal after amniocentesis. So it definitely throws up a lot of confusions whenever the patients will get a report showing a non 13, 18, 21 related abnormalities, and the pickup rates of the laboratory will be difficult. So expanded panels, I think it creates more confusion than really helping the clinicians around. My last question actually, and that's to the whole crowd actually. What is easy to manage? A false negative test or a positive test? And it's open to all actually. Please think. What is easy to manage? A negative test or a positive test? Or what is difficult to manage? A negative test or a positive test?
Getting rid of that false word, negative test is easy to.
No, don't false, say false. I'm taking that first rate. A negative test or a positive test? Positive is easy. Yes. No, I think when those of you are doing ultrasound, the most difficult sentence of ultrasound report is everything is normal. Don't worry, things are fine. And that's the most difficult sentence any sonologist would like to utter. So managing a negative test is more difficult than managing a positive test. So the clinicians have to keep it in mind what is the sensitivity and the specificity of the test that they are advising in their population. What is the sensitivity? That is the ability of the test to pick up the really affected person, versus specificity, that is the ability of the test to rule out the disease in that given specific person. So this specificity and sensitivity of the test has to be known for every test by the clinician, and definitely a clinician will have to have a backup plan ready to tackle the unpleasant situations. I think I'll stop over here, but this is my just last slide in just sensitizing you about, we speak about the economic divide, we speak about the social divide. Yes, Dr. Dabade sir has a point.
Today, I have 2 questions for you. First, you said because that lady went for NIPS directly, and you all were grumbling, she went directly. She went, she has come with the report, and you are stressing that she should have undergone pre-natal counseling, pre-test counseling. Okay. She could have come to you with the report, and then also you could counsel her. So why it was insisted? My question is why it was again insisted that pre-test counseling should be done. That's one question. And secondly, for all those high-risk patients aged more than 35, everybody talked about go directly for invasive. Okay, I do agree invasive is going to give you a concrete report, but is it safe? Is it not going to harm the pregnancy? These are the only 2 questions I expect answers from you.
Yes, I'll try to answer this, and these questions will again be answered by the panel also. Number one, whether the patient should have gone to the test, what's wrong if the patient goes directly for a test. It is the test, NIPS is not something like doing a CBC without telling the doctor. So there has to be a pre-test counseling in a sense. The patient needs to know what is to be done if the test comes positive. If the patient has no idea about what is to be done, if the test comes positive, she will come with a request like this, the termination of the pregnancy. So patient needs to understand कि boss मेरा test positive आ गया तो मेरे को क्या करने का है. The laboratory or the doctor should also have a mechanism in place to tackle these screen positive patients. For that matter, in my clinical practice, I'll tell you my example. If the patient goes an NIPS screen with me, then I would tell ki look, if it is negative, fine. We'll be doing your ultrasounds as per the protocol. If the test comes positive, we'll undergo an invasive procedure for which you're not going to charge anything to you. So we have a tie-up with the lab, says ki lab will not charge any money from that. We also don't collect any money for the invasive process. So patient goes with the confidence that, okay, doctor is not trying to cheat me, or not, doctor is not trying to earn by doing both the testing. So we give that assurance ki boss, our screening strategy is so robust, or the laboratory with which I work is so robust, and the laboratory looks at the audits so nicely that the laboratory is very sure about their reports. In case your reports comes abnormal, the lab will do entire lab cost free of cost, and we are also not going to charge you. So that's one confidence that the patient will have when the patient goes for a test, pre-counseling.
And sometimes we need to advise NIPS advance as well. That decision I think clinician takes. Whether it is simple NIPS or sometimes on ultrasound findings, advances where we want to see the microdeletions as well. So that comes after counseling.
Yeah. The second issue about 35 years and above pregnancy, I definitely agree with you. Ultrasound will be more important in deciding which patients will go for. Role of direct invasive testing, actually, if you look at all FMO criteria and the way these markers came, was to reduce on the number of interventions rather than increasing the number of interventions. Definitely intervention has a problem, and for that single lady, she is taking almost a 50% chance of losing the pregnancy with your invasive procedure. Though we may say in my hands the loss rate is 1 in 200 or 1 in 300 or 1 in 400, patient is taking almost a 50% chance. So, though your chances of pregnancy loss following the procedure would be little lesser, I think we have to take a proper judgment on that. Of course, that's open to the rest of the panel to answer this question. Both.
Maternal age has only 30% detection rate. Maternal age. So you cannot give so much emphasis on maternal age because that gives maternal age detection is only 30%. Because the remaining 70% down babies are born to younger women. So just because she is 35, she doesn't automatically go into high risk, although notionally she may be going in a higher risk. So secondly, whenever we point for and against non-invasive, you have safety, but you are losing reliability. In diagnostic test, you get reliability, but you sacrifice safety. You can't have the cake and eat it too.
Very true. I thank you, the panel, for this very nice knowledge sharing. As always, I think genetics is throwing up lots of challenges for us, and we as fetal medicine consultants to have this Nirakshi Vivek in interpreting the test. So a lot of responsibilities on our shoulders to interpret, because this test comes with a lot of ethical and social responsibilities also, implications also. Thank you so much for your patient hearing. And thank you, Gokte sir, for putting your views, and rest of my panel for contributing their views also. Thank you so much.
I was trying to contact Dr. Sharad, Dr. Ajit, but all this is a find of Dr. Sumit Chamaria. So Sumit, we definitely appreciate, and you all as well. Like, this is how the actual fellowship starts, and I'm so happy that all of you are here.
I request Ajit Patil sir and Sharad sir to please join in for the felicitation of our panelist, Dr. Keval Patil sir. Dr. Raviraj Konkar sir. Dr. Ankita Deshmukh. Dr. Ankur Shah. I request Milind Shah sir and Neeta ma'am to please felicitate our moderators for today, who have made all of them speak. Dr. Ajit Patil sir and Dr. Sharad Gokte sir.
You know, friends, Dr. Sharad Gokte and I am associated because of ISPAT, Indian Society of Prenatal Diagnosis and Therapy. And 20 years before, we were together under one platform, and since then our friendship continued in spite of the age difference. So wonderful.
I request all of you to please stay for a group photograph of the panel discussion, so that after that we can start with the next panel. Without wasting much time, we will be starting with our next session, which is a panel discussion on extreme prematurity, moderated by none other than Dr. Vandana Bansal, Madam.